Our host Dean, School of Medicine, Professor W. Olayemi. The Dean of Akhigbe is represented here by Dr. John Akhigbe. Faculty of Arts is represented by Professor A.O. The Dean, School of Basic Clinical Sciences, Professor V.J. Olayemi. The Dean, School of Basic Medical Sciences, Professor F. The Dean, School of Dentistry, Professor F.O. Omoride. The Dean, Faculty of Education, Professor K.O. Omorogiwa. Dean, Faculty of Engineering is represented here by Dr. C.I. Akhigbe. Faculty of Environmental Sciences, Professor Biographical. The Dean of Law, the Dean Faculty of Law is represented here by Dr. Jacob Karuga. Dean Faculty of Professor N.J. Obi. Dean Faculty of Management Sciences is represented by Professor A.O. Olayemi. The Dean Faculty of Pharmacy is represented by Professor Akhigbe. The Dean Faculty of Physical Sciences, Professor E.O. Akhigbe. Dean Faculty of Social Sciences, represented by Dr. I.M. Adedo. Director, Center for Distance Learning, Dr. D. Aiko Egomari. Director, Center for Entrepreneurship Development, Professor E. Olayemi. Director, Center for Educational Technology, Professor H. Olayemi. Director, TETFO, Center of Excellence, Professor Mrs. Ijoma Obu. Director, University of Advancement and Development, Professor Eddie Eraigbe. Director, Advanced Digital Engineering Center, Professor Mrs. B.E. Orugwe. Director, Institute of Childcare, Professor Mrs. Ayebo Sabo. Director, Student Guidance and Counseling, Professor Mrs. O.N. Akhigbe. Acting Director, Institute of Public Admin and Health Services Management, Dr. E.O. Ogato. Leading the Vice Chancellor's profession is Senior Assistant Registrar Senate Matters, Mrs. Ineye Odia. And I have the honor and privilege to invite our dear Vice Chancellor to introduce the inaugural lecturer for today.
Great Unibeg, greatest Unibeg. If we say here that our middle salary will be tied to recitation of the national anthem, I think, Bossa, the way we go ahead. The principal officers of this great university, the proposed college of medicine, deans of faculties and schools, directors of institutes, members of council and senate, all our distinguished retired professors and semi-professors, my Lord, spiritual and temporal staff and students of this great university, distinguished invited guests, and friends of the university, gentlemen of the press. Of course, many things have been said about our Vice Chancellor, who we know is the chairperson of all Vice Chancellors in no more than 250 universities in Nigeria. Presently, they are in somewhere in the south, where she's chairing the conference of female Vice Chancellors in Nigeria. I will pray that God sustain His protection from her. I will read her speech. It is my pleasure to welcome you all to the 312th in the inaugural lecture series of the University of Benin. Today's lecture is the 83rd to be delivered in my tenure as the Vice Chancellor of this university. From and the 63rd in the School of Medicine. I am glad to inform you all that our academic calendar is running smoothly, and I thank all stakeholders for the understanding they have shown, particularly with respect to the recent challenges of prohibitive increase in electricity tariff. The matriculation ceremony for the 2023-2024 academic session has been scheduled for Thursday, 13th June 2024 at this venue. Thank you. Ladies and gentlemen, may I introduce our lecturer for today. She is Professor Mrs. Adenike Olayemi. The title of our lecture is Medical Imaging to the Rescue. Professor Mrs. Akhigbe was born on the 3rd of March 1956 in Inaugural, Ilaje local government area of Ondo State, to the family of Mr. Simeon Odadipo Tubo and Chief Mrs. Paulina Mariola Tubo, both of blessed memory. She attended local authority primary school in Otikba from 1962 to 1968. For the first school leaving certificate, she had a secondary school education at Methodist High School of Otikba, where she obtained the West African School certificate in 1973. Professor Akhigbe worked briefly in Lagos as a primary school teacher before she gained admission into the School of Medicine, University of Benin in 1978, where she obtained the Bachelor of Medicine and Bachelor of Surgery MBBS degree in 1984. She was a house officer in the University of Benin Teaching Hospital from 1984 to 1985, after which she did a one-year mandatory national service between 1985 and 1986, starting in Kwara State, but later completed it in the University of Benin Health Services. What would be the reason for that? Well, I will not blame her, because up to today, men are still scarce. And that's why in our language we say, men are scarce. That's why you see fraud carrying his own husband behind it in the river. So if you decided to come here, it's because of this our father. Thank you very much. After her service, she worked as medical officer at Beverly Hospital and Faith Medical Center, both in the city, from 1986 to 1992. Professor Mrs. Akhigbe had her residency training in radiology at the University of Benin Teaching Hospital between 1992 and 1998, thereby obtaining the postgraduate fellowship of the West African College of Surgeons. She joined the services of the University of Benin in 1998 as lecturer 1 in the Department of Radiology, School of Medicine, and rose to the ranks to become a professor in 2015. Professor Akhigbe has been a consultant radiologist in the University of Benin Teaching Hospital since 2000. She has had several post-fellowship specialist trainings, for example, vascular ultrasound in USA, breast imaging in USA, and adults and pediatric echocardiography in India. Professor Akhigbe has held so many administrative positions, some of which include lecturer in charge, Department of Radiology 2002 to 2004, acting head Department of Radiology 2007 to 2009, head of Department Consultant Radiologist, University of Benin Teaching Hospital 2002 to 2004, then 2007 to 2009, acting director of Biomedical Communications Unit, College of Medical Sciences, University of Benin 2012 to 2017. Professor Akhigbe is a member of several professional associations and bodies, some of which include member Nigerian Medical Association, member Medical and Dental Consultants Association of Nigeria, Adenike, member Association of Radiologists of West Africa, member Nigerian Society of Neurological Sciences, member Radiological Society of North America, member Association of Radiologists of Nigeria, member Breast Imaging Society of Nigeria, member Fellow West African College of Surgeons, and Fellow International College of Surgeons. Professor Akhigbe has over 40 articles in local, national, and international journals. She is a professorial rank assistant to several universities, and she has also attended national and international conferences, several national and international conferences. She has served in various accreditation panels of the Nigerian University Commission. She has been a postgraduate examiner to the West African College of Surgeons since 2015. She has supervised over 40 postgraduate dissertations for the West African College of Surgeons and National Medical College. Professor Akhigbe has passion for singing and traveling. She is married to Professor Kingsley Akhigbe, a psychiatrist in the Department of Mental Health, School of Medicine, with children and grandchildren. Ladies and gentlemen, it is my pleasure to invite Professor Akhigbe to deliver our inaugural lecture.
Thank you very much. My Vice Chancellor, represented by Professor Adenike, the DDC Ekewa campus. Allow me to stand on the already established protocol by the University PRO. This inaugural lecture is dedicated to the Lord Jesus Christ, the Son of God, who is the Lord of our heart and the Savior of our soul. The appreciation to God Almighty and tremendous joy in my heart, I stand before this distinguished audience to deliver my inaugural lecture. Madam Vice Chancellor, I'm grateful for the opportunity to present the 312th lecture in the University of Benin Inaugural Lecture Series and the second from the Department of Radiology. I am a graduate of the University of Benin Medical School, entering the school in 1978 and I graduated in 1984. During my time as a student in this great university, there was no ASU strike. I had my residency training in radiology at the University of Benin Teaching Hospital and obtained a fellowship from the West African College of Surgeons in the Faculty of Radiology. In 2005, I was on a self-sponsored fellowship in Doppler ultrasound and vascular imaging at the Thomas Jefferson Teaching Hospital in Philadelphia, USA. While at the fellowship program, I saw a television advertisement about mammography screening for breast cancer. This brought to my mind a sad experience of a close friend who passed away from breast cancer at a young age. I could remember that she told me she had a lump in her breast when she was breastfeeding her second child at the age of 32 years. This happened in the early 1990s, when breast imaging understanding was limited. I decided to really call to have my first mammography screening at the Philadelphia Teaching Hospital. And for this screening mammography, I had to pay a discounted fee of $300. Thank God the screening was negative. But this drew my attention to the fact that I would need to have a fellowship in breast imaging, for which the following year I went back to Thomas Jefferson University for a fellowship in breast imaging. And since I came back, I have spearheaded the practice of mammography screening in the Benin City and Edo State axis. With this, I've spearheaded the practice of mammography screening, even starting before the teaching hospital acquired mammography machine. And I have taught several resident doctors breast imaging in the teaching hospital. I am a founding member of a Breast Imaging Society of Nigeria, Bison, where I served as the immediate past president up until December last year. In my practice as a breast imaging specialist, I have seen women, both young and old, presenting with breast cancer. Majority of these cases, they present late. An example was a 34-year-old woman who presented with jaundice due to late-stage breast cancer, and she was referred for general abdominal scan. At the scan, we found out that she had metastatic liver disease, which later was traced to a right breast cancer, which was confirmed. Unfortunately, within 1 month of that diagnosis, she passed away. Madam Vice Chancellor, my inaugural lecture is titled, Seeing the Unseen, Medical Imaging to this Rescue. Seeing the unseen can have different interpretations depending on the context. In philosophical or spiritual terms, it refers to perceiving things not visible to the naked eye or mind. In art, it metaphorically captures emotions, ideas, or experiences not immediately apparent. In scientific context, however, it involves using imaging technologies to visualize invisible objects or phenomena. There was a news item about 4 weeks ago about an 11-year-old girl, Tia, who saw her doctors 30 times, and the 30 times she was misdiagnosed. The diagnosis was missed. She had headaches, nausea, she had visual problems to the extent that her glasses was being changed frequently. But until she had an MRI of the brain done, that was when the diagnosis was found that she had a brain tumor. That is, which means that seeing the unseen is a universal phenomenon. The overarching theme of seeing the unseen in the context of medical imaging is a powerful and evocative concept that encapsulates the essence of what radiologists and medical professionals do. This theme underscores the transformative ability of radiological imaging techniques to reveal hidden aspects of the human body and provides insight into the following: revealing hidden pathologies. Radiological imaging will help us to see the inside of the body and identify disease conditions such as fractures in cases of trauma, collection within the brain in head injury, or brain tumors, as in the case of the Tia 11-year-old girl. Early detection, number 2. Identifying disease in the early stage before symptoms develop. Early detection of disease through imaging has led to the introduction of screening programs such as mammography screening for breast cancer. Precision medicine. This is a modern health care concept where Medicare is tailored to individual patients' needs using radiological imaging for individualized diagnosis, treatment planning, targeted therapies in oncology, and to monitor treatment response. This precision medicine promotes patient-centered care. Minimally invasive medicine, a medical approach that minimizes trauma because of the use of imaging for visualizing the internal organs. It's possible to use to make just a little incision, and the therapeutic goal is as good as traditional open surgery. This reduces trauma, it lowers infection risk, and it also improves cosmetic outcome. And some of such procedures, they can be done on outpatient basis at daycares, and it also promotes early return to work. This is what imaging has been able to achieve. Patient empowerment. By seeing their scans and images, patients will understand their health conditions better, and this empowers patients and promotes them with having active patient involvement in healthcare decisions. When they understand their test results, it's easier for them to have shared decision making concerning their treatment. Hope and healing also is brought to the patient. It answers patients' uncertainties and improves prognosis, boosting their motivation and alleviating fear. Also, the repetition of imaging at times also shows them evidence of progress during their treatment. Research and discovery, innovation and progress. These are things that medical imaging has been able to achieve. It aids in non-invasive drug testing and development of new technologies. What is medical imaging? Imaging can be defined as the application of a range of technologies or tests to create pictures of parts of the body, which can be used to diagnose a likely cause of existing symptom, screen for possible health conditions before symptoms appear, or treat medical conditions. 3 key professionals are involved in imaging, in medical imaging. These are radiologists, radiographers, and you have the radiation oncologist. By way of history of medical imaging, X-ray is the oldest imaging modality, and it can be traced back to 1895, when the German physicist Wilhelm Röntgen made a breakthrough discovery while experimenting with cathode ray tubes. Röntgen directed the ray through various objects, including his wife's hand, and he was the one who gave it the name X-ray, which means unknown ray. The X-ray can penetrate tissue and makes bones and metals visible. This was the first X-ray that was done. Röntgen's wife's hand, Anna Beta, that showed the bones of the left hand and the ring finger with the marriage finger, with the ring on the ring finger. There has been evolution of radiological imaging. Fluoroscopy, developed in the early 20th century, is an imaging technique that uses X-ray to obtain real-time moving images of the interior of the body. Computed tomography, CT, was introduced in the early 1970s by Sir Godfrey Hansfield and Alan Kochmark. They were able to create this imaging modality that gives detailed cross-sectional images of the body. magnetic resonance imaging, MRI. This was developed in the early 1970s and early 1980s, and it uses strong magnetic fields and radio waves to generate detailed images of organs and tissues within the body. Unlike X-ray, CT, or fluoroscopy, MRI does not use ionizing radiation. Evolution of radiological imaging also brought about ultrasound technology, which uses high-frequency sound waves to create images. This has significantly advanced since its medical introduction in the 1950s. Modern ultrasound machines often offer enhanced image quality and real-time visualization. Nuclear medicine, this involves the use of small amounts of radioactive materials called radioisotopes to diagnose and treat diseases. This field has grown significantly since the 1950s, and it forms part of the fusion imaging technique where you combine structural imaging and functional imaging is combined, such as PET-CT, PET-MRI. The radiological imaging has helped us in screening for various diseases and conditions. Mammography for breast cancer screening, regular mammogram detect breast tumor early, improving treatment outcomes. Colorectal cancer screening, low-dose CT scan screening for lung cancer is also another introduction, which is meant for high-risk individuals like heavy smokers. Ovarian cancer screening for those who are at risk, high risk, those who have family history of the disease. They can have transvaginal ultrasound scan to monitor changes in their ovaries, and so many other screening modalities. My practice and research contributions. I have worked with colleagues in many disciplines to do collaborative research, and because medical imaging is a practice-based field, I have fully participated in hospital-based responsibilities, revealing the hidden diseases of several patients. I'll present some case studies from my practice that demonstrates the transformative power of imaging in diagnosis, as well as my research findings that underscore the need for medical imaging as a veritable tool for unveiling hidden pathologies. This was a case of stroke diagnosis. A stroke occurs when the patient's blood supply is interrupted. The brain's blood supply is interrupted, causing damage. It's a medical emergency. I'm sure many of us have heard or seen individuals with stroke. The most common type of stroke is ischemic stroke, which is caused by blockage of brain artery to a particular part of the brain. The hemorrhagic stroke, which is another type of stroke, is less common. And this occurs when blood vessel in the brain breaks and leaks blood. Early diagnosis through brain imaging helps determine the type of stroke which guides treatment decision. So without a CT done, like this on the screen, it's not possible for you to know whether this patient has hemorrhagic stroke or ischemic stroke. The first one I'm pointing to is a case of ischemic stroke, where you have this area of the brain was affected. And this second one was a hemorrhagic stroke in which this part of the brain, there's bleeding into this part of the brain. And this was a hemorrhagic stroke. Early detection of breast cancer with mammography. A woman undergoes a routine mammogram which detects a small early-stage breast tumor that is not palpable during a physical examination. This was the case of this lady. This tumor that is small here was not palpable, but eventually it was found to be a cancer. And for this kind of finding, higher survival rate and better quality of life is possible for this patient. Mammography is instrumental in reducing breast cancer mortality. Here was a lady who presented with swollen breast, and her story was that she had this boil in her breast, which she had been taking antibiotics for. And she had had antibiotics for several weeks, but the swelling was progressing. That was this right breast. So this mammogram is showing us this angry-looking swelling in the right breast with swelling of the breast and involvement even of the lymph node in that right axilla. This was an advanced case of breast cancer, which will require some more extensive treatment compared with the one that was diagnosed at an early stage. This was a case of a 61-year-old woman who presented with left-sided chest pain and had an echocardiogram done. Echocardiography revealed a large mass within the left atrium, which was attached to the septum here. And each contraction of the heart on ultrasound, because this was a 4-chamber view of echocardiogram, you'll see the mass protruding through the mitral valve and causing heart pain. Usually, most cases of this kind of mass is called by cardiac myxoma, which is a benign mass. But this will require open heart surgery. Thanks to UBTH that has now started offering open heart surgery, ably led by our CMAC, Professor Akhigbe. Here was an old man who matched an unknown object. And, in our setting, you have some traditional beliefs that will think that, oh, maybe this man has matched something sinister, which they may call juju. And they may go to the extent of even sacrificing some fowl or goat to neutralize the juju. But this will not remove the pain. But here, X-ray has come to the rescue, because X-ray of the leg revealed a broken needle at the heel of this old man, and so solution came to him. Uterine fibroids. A lot of women present with uterine fibroid, which causes infertility. And many of them, they are afraid to have surgery done. So they will rather buy the idea of taking some drugs that will melt the fibroid. I have seen many who have taken drugs for months, and they have come to check whether truly the fibroid has melted, and you will find the fibroid is even getting bigger. Now, for this woman, she had hysterosalpingogram done. The hysterosalpingography, HSG, showed that the fibroid mass was occupying the whole of the womb, the uterus. And with this image, it was possible for this woman to be convinced that she will need surgery to remove the fibroid so that she can be pregnant, so that she can have a baby. And so seeing this image was helpful to her to take a decision. Here was another case in my practice where a lady was diagnosed with acute appendicitis. And when she came for a general abdominal scan, what we found was different. We found this huge mass, which was at the top of the womb. This is the womb, the uterus. This huge mass was a pedunculated fibroid that had twisted. The stalk has twisted. And that was what was causing her pain. But to the physicians, they didn't see this, but seeing the unseen, imaging came to the rescue. This was ultrasound that came to the rescue of this patient. Male breast cancer. The usual belief is that when you talk about breast cancer, it is strictly for women, but it is not true. Men also can develop breast cancer. There was this 82-year-old man who presented with a history of left breast painless lump and had a mammography done. The mammogram is what you are seeing, and it showed this mass that was eventually discovered to be malignant. So he had breast cancer. Yes, breast cancer is rare in men, but it can occur. Therefore, men also need to be breast aware. They need to also examine their breast. You don't have to come for screening mammogram because of the the incidence, which is low, but it is possible. So the men should also examine their breast. And if there is any lump in your breast, please go to the hospital and let it be confirmed that it is benign. Now, this was a case of late presentation of anencephaly, psychological aspects and implications, Akhigbe and Akhigbe, 2006. We examined this 33-year-old lady who has had 10 pregnancies. And this 10th pregnancy, at 42 weeks, she was in labor. And after several hours in labor, there was no progress. And that was why she was sent for this scan. And the scan revealed that there was no fetal head. The baby had no head. This was the ultrasound image, which the spine, this is the backbone here, which ended abruptly without a head. And this was the baby after being delivered that had only face but no head. This diagnosis could have been made in the first 13 weeks of pregnancy if this woman had had an early scan. And this underscores the need for women when you are pregnant. You need to do a scan early to be sure that you are not having ectopic, that is pregnancy outside the womb, and to be sure that your baby is growing well. Follow up also to be sure that the baby does not have this significant congenital abnormality as the one reported in this case. Unsuspected pregnancy at hysterosalpingography. Akhigbe, Oyobere, and Uka, 2009. HSG was done for this lady because she had 9 months of not seeing her period as a result of previous D&C, termination of pregnancy. And the HSG, when it was done, we found this enlarged uterus, and we thought it was fibroid. But on ultrasound, we discovered that the filling defect and mass within the womb was because of a 10-week gestation that was within the womb. Unbelievably, because she did a scan 2 months earlier that revealed that she was not pregnant. That was what she presented to us in the department. This is a rare occurrence, and that was why it was reported. And really, after reporting this, when it was published online, I received many calls saying that, asking questions whether, it's possible to still have, because such people had an experience like that, whether it's possible to still have normal baby after that. And when we looked at the exposure, the radiation exposure, we found that it was not as significant as to be worried. So we followed up the woman. And eventually, she had a full-term female baby that weighed 4.3 kg at 41 weeks. And the baby was complete. There was no abnormality seen. This was the image, and this was the ultrasound image that showed the baby at 10 weeks gestation. Missed and delayed diagnosis of diaphragmatic hernia. Diaphragmatic hernia can occur as a result of blunt abdominal trauma. And that was what happened to this 28-year-old young man who had a misdiagnosis of pulmonary coccyx when she had a chest X-ray done 21 months after the trauma. She did not present immediately after the trauma until about 21 months later, when she noticed she was having this pain on the left side of the chest and some other complaints. So the chest X-ray revealed what looked like Cox disease, TB, and he was on TB treatment for 8 months. It was during the follow-up chest X-ray that it was observed that this could not be TB. And then he was sent for chest CT. Chest CT now revealed that there was a rupture of the left hemidiaphragm with herniation of the stomach, here was the stomach, and small intestine into the left chest cavity. And that was what was causing the problem. So CT came to the rescue of this young man because there was no way she would have gotten better with anti-cox treatment, finding out that this was what he had. Pattern of CT findings in patients with clinical suspicion of intracranial suspect occupying lesion. Akhigbe, Oguni, Akhigbe, 2002. Space occupying lesion in the brain can present with various symptoms, clinical symptoms. Some may have headaches that is not remitting. Some may have seizure, that's convulsion. Some may have difficulty in seeing. Some may have stroke. Some may even present with mental disorder. But in this case, when we examine these cases of people who had that history, we found that some of them had stroke, some had brain tumors, some had blood clots within the brain, some had shrinkage of the brain called cerebral atrophy, some had hydrocephalus, which means fluid collection within the ventricles of the brain. Some had brain abscess. However, 40% had normal CT. But it's important for us to know that not all headaches will respond to paracetamol treatment. And that is why it's written that if your symptom persists, you should see your doctor. And when your doctor says, go and do CT, please do it, because it may save your life. Ventricular septal defect in adult Nigerians. Uko and Akhigbe, 2008. We had a prospective study of echocardiographic findings among 1,324 adults. About 13.8% of these adults had congenital heart diseases, predominantly ventricular septal defect. A few of them had other coexisting congenital anomalies. But it was surprising to see adults with congenital heart disease. But the explanation may be that some of these adults may have presented earlier, but because they did not do imaging, the diagnosis was not reached. And some of them must have lived below their expected performance because of this disease. But here you have adults having congenital heart disease. Effect of medicinal leaves on rabbits, biochemistry and ultrasonography. This was a collaborative study with Faculty of Science, Akhigbe, Idu, et al., 2009. This was one of the collaborative studies I had with others from different faculties. We administered extracts on rabbits, and we did ultrasound of the rabbit. And we found that the significant finding in this study was bradycardia, slow heart rate. Our conclusion was that this could be treated as side effect of this extract if administered to people. And this is how drugs are also discovered and drugs are tested. So this was like testing this extract using rabbit. Now, talking about mammography, breast imaging. We looked at pattern of utilization of mammography experienced from Benin City, Akhigbe and Igbenedion, 2010. In this study, we looked at the use of screening mammography vis-a-vis diagnostic mammography. Screening mammography is when you do a mammogram to screen where you are asymptomatic. You don't have any symptom. You have just come to check your breast for possible abnormality. That is screening mammography. While diagnostic mammography is when you have symptom and you come to do mammography to look at what is causing your symptom. These are two different things. And in developed countries, why they have this reduced mortality rate is because majority of the women go for mammographic screening But here in Nigeria, this study revealed that we have very low yield of screening mammography, only 15.6%, compared with over 70% in developed countries come for screening mammography. They would rather wait until they have symptoms, and this is not in our favor. We need to begin to do screening, to screen for breast cancer. This was another mammographic study, or another study about breast imaging, knowledge, attitude, and practice of breast cancer screening among female health workers in Benin City. Akhigbe and Olayemi, 2009. The study included 393 female health workers. You have doctors, female doctors, nurses, radiographers, laboratory scientists, and pharmacists. We found that the use and even knowledge of mammography as a screening method was very low. And no wonder, they also had very low mammography screening practice, 3.1% mammography screening practice. And this became, this was of concern to us, because if health workers who are supposed to tell the people in their communities to do screening for breast cancer have poor knowledge, where are we going to? So we need to really expand our coverage of mammography screening campaign, especially starting from the health workers who are supposed to be custodians of the knowledge of diseases in our society. Breast cancer screening in Nigeria, impact of health belief and cancer fatalism. What is cancer fatalism? The belief that death is inevitable when cancer is present. This has been identified as a barrier to participation in cancer screening, detection, and treatment. And this study was Akhigbe 2012. The study involved 225 women aged between 30 and 60 years. And we found that the women show significant barrier to even regular breast self-examination, which, even though the yield is low, it was even worse with mammography, that they wouldn't come to screen for breast cancer unless they have symptoms, unless there is a lump, which may not be helpful at that stage, because it is better when breast cancer is diagnosed before it becomes palpable, before it shows symptoms. So from this study, we also concluded that we need to understand the psychological and psychosocial barrier deterring adequate breast cancer awareness and routine screening in Nigerian women, so that we can develop such instruments that will encourage the women to come for screening. There are emerging trends in imaging, and that is the next slide. Artificial intelligence is beginning to take center stage in image analysis and reporting. There's an ongoing multi-center AI testing in mammography reporting in Nigeria, with Nigeria and a company in the USA. And UBTH is represented by Akhigbe and Agaoba of Radiology Department and Professor Ekanem of Histopathology Department. Telemedicine and teleradiology, which enables remote consultation and mobile imaging, is already being practiced in Nigeria. These are emerging technologies helping us to do better in imaging. My recommendations. For the government and public hospitals, they need to address the brain drain of radiologists and radiographers by providing career development opportunities, improve hospital working conditions through facility updates and supportive work. They need to enhance residency training by allocating more funds to residency program for training, research, and professional development. They need to invest in medical imaging infrastructure, especially X-ray and high-end ultrasound machines. Equipment maintenance and upgrade also needs some concern to establish a robust maintenance schedule for imaging equipment, providing continuous training for biomedical engineers and technicians so that our equipment will not be breaking down and remaining unrepaired. Manpower development is also another area. They should invest in regular training programs for imaging professionals and then encourage subspecialization in various imaging modalities. Recommended breast cancer screening guidelines for Nigeria. Primary screening population, women aged between 40 to 69. It doesn't mean that if you are above 69, you should not do screening. It is still necessary for you to do screening. But this younger generation, we recommend annual screening for women aged 40 to 49, 2 yearly for women aged 50 to 69. And the screening method remains mammography, which is the gold standard for early detection, not breast self-examination. Mammography screening remains the gold standard for early detection. Additional screening for high-risk groups is also recommended in women from the age of 35 for those who are high risk. And with this, you also consider the use of supplemental imaging like ultrasound to increase the yield. We need to also establish a national breast cancer registry for data-driven approaches in all this. By adopting a structured and evidence-based breast cancer screening program, Nigeria can significantly improve early detection rates and outcomes for women. Implementing these recommendations requires a coordinated effort from the government, healthcare providers, and the community to ensure that seeing the unseen, medical imaging to the rescue, translates into tangible benefits for all Nigerians. Conclusion. Advancements in medical imaging technology, from William Röntgen's X-ray discovery to today's imaging modalities, have significantly improved patient outcomes. Imaging interior structures had made the invisible visible and the unsure certain in healthcare, thus promoting seeing the unseen. These technologies improve patient outcomes through timely diagnosis, such as early breast cancer detection and precision surgery planning. Radiology's brain drain and technical development are challenges. By harnessing the power of medical imaging technologies and maintaining high standards, we can bring hope and healing to countless individuals. My acknowledgments. My heartfelt thanks goes to the Vice Chancellor, Professor Lillian Imwetinya Salami, for the opportunity to deliver this inaugural lecture. Members of the university management deserve special recognition. They are Deputy Vice Chancellor, Administration, Professor Ukponwa, Deputy Vice Chancellor, Academic, Professor Ozolwa, Deputy Vice Chancellor, Akenwa Campus, Professor Anyide, the Registrar and Secretary to the Council, Mr. Bobola, the Acting Bossa, Mr. Osadolo, the Librarian, Barrister Megasin, Provost College of Medical Sciences, Professor Wilson Sado, and other members of the university administration, and my Dean, Professor Wilson Osaro-Giagbon. The members of the Department of Radiology deserve special appreciation, including Professors Mache Adeyekun Igbinedion, Doctors Ehigiamusoy, my HOD, Igodaro Agbahowe, John, Oni Samson Akpede, Doctors Owen Arigbodi, Anemena Agawa, Osagboge, Asekame, Odige, and other senior and junior residents. Mr. Usen, Mrs. Binedo, and Mrs. Oladipo are the radiographers that have kept the department going due to brain drain. I gratefully acknowledge the administrative staff of UNIBEN and UBTH, nurses and other technical staff in the Department of Radiology. I'm deeply grateful to my parents of blessed memory, my eldest sister, Chief and Dr. Mrs. Osemobo, all my siblings, my in-laws from Aviosi and Mosoga, my Christian brothers and sisters from CU Alumni Association, my fellow pilgrims, especially ministers and members of Church of God Mission International, and the Christian Women Fellowship International, Kwifi in blue. God bless you for coming. My benefactors, my colleagues at work, including doctors, nurses, and all health workers, my colleagues in the university, both teaching and non-teaching staff, the staff of Sharon Diagnostics, and many others. The list is extensive, and I'm truly thankful for the support and influence of every one of them. I'm grateful to my teachers in the medical school, among whom are Professors Ofegu, Ojogu, Ogisi, and Wawa, past provosts of the College of Medical Sciences, and past deans of the School of Medicine. Of special note are Professors Okonofo and Abiodu, two prominent lecturers that were an inspiration to me in preclinical years, Professors Ijawe and Odekunle, my classmates in the medical school. I remain grateful to Dr. Ojobo, Akhigbe, Dr. Eboehi, as well as a host of other healthcare providers in private practice for their support through the years. I would like to thank Professor McDonald Idu of the Department of Plant and Biotechnology and Professor Madukwe of School of Dentistry for encouraging my research efforts. The non-teaching staff of the university have been such great support over the years, and Mrs. Comfort Ehigiato stands out for mention. I want to thank my professional colleagues who have been such wonderful people, members of ARIN, Association of Radiology in West Africa, Breast Imaging Society, Bison, Medical Women, Edo State Branch, and Association of Nigerian Private Medical Practitioners, Edo State Branch. I'm thankful to my trainers across borders. In closing, I wish to offer effusive thanks to the Most High, the God and Father of our Lord Jesus Christ. His divine mercy has blessed me abundantly, particularly through the gift of my husband, who has been my friend and brother. His unwavering support and love have been a constant source of strength and joy in my life. Furthermore, I'm profoundly grateful for our wonderful children and grandchildren. You are blessings in every way. Their love, laughter, and presence enrich our lives immeasurably. And I thank God for the precious gift of family. I thank you all for listening.
Please put your hands together. I believe everybody here has benefited something. Thank you, Lord. I now respectfully invite the Vice Chancellor for a recap of the lecture.
Behind every successful woman, behind every successful woman is a man. A round of applause for Professor Akhigbe. You know, we have to say this because the commanding tone that he used at that time to bring her all the way from Kwara to Benin. If he had stood on that and said, this woman, you are not going to go to any school again, we will not have been here today. Kudos to you, sir. The lecture, seen and unseen, seen and unseen, medical imaging university examined how medical imaging technology have revolutionized healthcare. The lecture emphasized how imaging has changed diagnosis, treatment planning. The lecture began with historical overview of medical imaging, and eventually she told us kind of is not the kind of results groundbreaking discovery of the human body, how all this became possible. She discussed with us the significance of this technology, stressing the need adoption of X-rays in the medical field after its introduction. She moved on to discuss the evolution of imaging modalities, including CT, MRI, ultrasound, and nuclear medicine. CT improves diagnostic accuracy by producing detailed images. MRI offers exceptional soft tissue contrast. Ultrasound offers real-time imaging, and nuclear medicine aids cancer diagnosis and treatment. The lecturer, being an accomplished radiologist and breast imaging specialist, offered a plethora of knowledge and understanding regarding the revolutionary potential of medical imaging. Our contributions include breast imaging, training and mentorship of many medical doctors. Research and innovation. She is actively involved in research, including collaborative work with colleagues from different faculties and other training institutions, helping to develop novel imaging procedures and techniques that improve patient care and diagnostic accuracy. She told us part of the problems that we have in Nigeria include radiologist brain drain. And she told us how to solve this kind of problem. To address these problems, she suggested improved working conditions, competitive pay, professional growth. All these are necessary for us to stem brain drain in radiology. Future directions include AI and machine learning in image analysis, 3D and 4D imaging, functional imaging and spectroscopy. Typical imagined medical imaging becoming much more advanced, revolutionizing healthcare and improving patient outcomes. Overall, the lecturer highlighted science and faith in healing, emphasizing medical imaging therapies that will save lives, improve treatment and inspire optimism for healthcare future. Ladies and gentlemen, just as they recommended that women should go for mammography, maybe once or twice in a year, maybe we'll ask us another time how many times men should go for mammography. Thank you all for listening. Good evening, everyone.
Family members of our young lecturer this evening to please come on stage as the acting Vice Chancellor will decorate our lecture. Immediate family. Please come on stage. We want to welcome the Director, Center for Sustainable Development, Professor Akhigbe. You're welcome, Baba. I would like to make welcome. Please put your hands together as they come up here. The husband of the inaugural lecturer, Professor Kingsley Akhigbe, who gave his own inaugural. We also welcome you, Dr. Benny Akhigbe. We welcome you, Darlington Akhigbe. We also welcome Fijiro Bobo. You're all welcome. We welcome you, Engineer Raphael Akhigbe. Dr. Mrs. Dorcas Akhigbe, you're welcome. Mr. Dan Aibawa. We welcome you, sir, to this place. We want to welcome the former Vice Chancellor, Professor Akhigbe. Please can you put your hands together to make him feel very welcome. We also welcome you, Emeritus Professor and Mrs. Raymond Lionel. We welcome Sir Amma. We welcome you, Emeritus Professor and Professor Mrs. Ofuebu. We welcome you. Please put your hands together to celebrate them. We also celebrate and welcome you, the Center Lead, Seri, Professor Friday Okonofwa. Please put your hands together. We welcome you, sir. We welcome the Special Assistant on Health to Edo State First Lady, Dr. Bridget Okwegwali. We welcome you, ma'am. Thank you for coming. Very welcome. The former CMD and DVC Union University, Professor Musa Bazwaye. We welcome you, sir. Please can we put our hands together to celebrate this person?
Oh, check off his.
We are glad to join us this evening, the former CMD Edo Federal Neuropsychiatric Hospital, Uselu. Dr. Welcome back. Our former Deputy Vice Chancellor at Adenike Campus is here with us, Professor Joel Abulaga. The Chairman, Adenike UTH, Professor Inaugural. You're welcome. We welcome you, Patrick Wadia. We welcome also Professor Stanley Okubo, CIMAC UTH. We also make welcome Professor DCMAC Clinicals, University of Benin Teaching Hospital. We also welcome Akhigbe, DCMAC Training and Monitoring, University of Benin Teaching Hospital. We also want to welcome the Chairman, University, the former Chairman, University of Benin Alumni Association, Dr. Benson Esan. We welcome you, sir. We welcome Professor and Dr. Mrs. Abraham Bogodo. Please put your hands together to celebrate him. Thank you very much. We also like to welcome Professor Kokure Irafona. You're welcome, ma'am. Professor Jennifer Akhigbe, we welcome you to today's inaugural lecture. Professor Adebola Adeyekwa, we welcome you. Professor Adebola Ehizene, you're welcome. Please can we put our hands together to celebrate this person. Professor Faustina Idu, all the way from the Department of Optometry, we welcome you, ma'am. We also welcome Professor Akhigbe Omoti. You're welcome to today's lecture. We welcome Professor Loretta. Professor Loretta Iniage. We welcome you. We welcome and appreciate your presence, Professor Caroline Omoti. Please put your hands together to celebrate this presence. Thank you very much for coming, Professor Martins Aisien. We also welcome you, Professor Godwin Atedo. We welcome Professor P.R.O.C. Adobame. We welcome you. We welcome Professor Antoinette Ofili. We welcome you, Professor Omolade Awodu. Please put your hands together to celebrate her. We also welcome Professor Mrs. Alice Umeni. Please put your hands together to celebrate Professor Umeni. We also want to welcome the proprietor of Continental Group of Schools, Mr. Akadelo. We welcome you, sir. And especially we welcome all ESCO and members of the Medical and Dental Consultants Association of Nigeria. We welcome you very much. For everyone who has come today, we say welcome and God bless you. This is how we like to conclude the 312th inaugural lecture of the University of Benin. Thank you for coming. We appreciate you. We will now be upstanding as we take the Akhigbe anthem and the last stanza of the national anthem. Last stanza of the national anthem. Thank you very much. We are all learning fast. Thank you. Please remain where you are. Vice Chancellor will lead the entourage out of the auditorium. Please remain where you are. I would like for this space here at the front to please be clear. Please remain where you are, everyone. Thank you. Kindly remain where you are.